Gender differences in musculotendinous stiffness and range of motion after acute bout of stretching. Biophysics Laboratory, Department of Human and Health Sciences, University of Oklahoma. Introduction. Stretching is commonly used to improve performance and reduce the risk of injury. Before athletics events, it has been suggested that stretching will decrease the amount of strain through a range of motion, ROM, thereby reducing the risk of injury. A stiffer musculotendinous unit, MTU, is thought to be better withstanding large and rapid forces better than a compliant system, thus reducing the likelihood of injury. However, there is little evidence to support the relationship between increased flexibility and reduced incidence of injury. Yet a recent study by Shehab et al. Found that stretching routines are still performed by high school athletes as an injury prevention strategy. In addition, there is little research indicating stretching improves performance. An acute bout of static stretching has been found to reduce muscle strength and power, impair balance, and increase muscle movement and reaction times. In addition, a study by Nelson and Kokkonen asked subjects before testing whether stretching would have a beneficial or detrimental outcome, and all subjects believed that an acute bout of stretching would result in better performance. However, because of the limited evidence supporting stretching before competition, the President's Council for Physical Fitness in Sports released a statement concluding that stretching may not prevent injury and may also compromise performance. Despite the discrepancy between knowledge and practice, stretching is still a major component of pre-activity warm-up routines, and therefore additional research is necessary to determine the precise effects of stretching on injury prevention. Many stretching studies use increases in flexibility as the primary variable. However, total ROM provides only a fraction of the information regarding the physiological changes in MTU. Measures of musculotendinous stiffness, MTS, in conjunction with ROM may provide a more comprehensive understanding of the biomechanical responses of the MTU. Musculotendinous stiffness is defined as the ratio of changes in passive force in a muscle because of its changes in length. It is generally calculated using passive angle torque and angle force curves during a passive stretch. The slope of any tangent to the passive angle force curve is recorded as the MTS. Tangential slopes can be calculated at any joint angle and quantitatively measure the amount of passive resistance throughout the given ROM. Therefore, stretching-induced increases in ROM and decreases MTS imply that not only is there an increase in ROM, but there is also a decrease in passive stiffness and altered viscoelastic properties of the MTU. It is well known that connective tissues of men and women differ physiologically. However, the mechanisms contributing to these differences are not well understood. Estrogen may play a role because estrogen receptors are presented in fibroblasts of tendons and ligaments, which may alter collagen synthesis and affect tissue behavior. Other hormonal functions throughout the menstrual cycle may also influence the behavior of the MTU. Ealing et al. Found significant decreases in MTS of the knee flexors during the ovulatory phase when estrogen and progesterone are elevated compared to all other phases of menstrual cycle. In addition, Ryan et al. Using peripheral quantitative computed tomography showed a positive relationship between the muscle size and MTS, providing a possible explanation for gender differences in MTS, as men generally have greater muscle mass than women. To our knowledge, only one study has compared the MTS responses to stretching between men and women. This study uses 3 60-second constant angle stretches of the plantar flexors to measure viscoelastic stress, relaxation, and passive elastic stiffness of each joint angle. However, constant torque stretches have been shown to result in greater decreases in MTS and increases in ROM than constant angle stretches. Therefore, the purpose of the study was to examine the MTS and ankle joint ROM changes in men and women after an acute bout of passive constant torque stretching. Methods. Experimental approach to the problem. A repeated measure designed pre versus post stretching that is depicted in Figure 1 was used to compare the acute effects of passive stretching of the plantar flexors on MTS and ROM in men and women. Each subject visited the laboratory on 2 separate occasions. The first visit was a familiarization trial during which the subjects practiced the stretch tolerance assessments, and the investigators determined the maximum tolerable stretching threshold that could be sustained throughout the entire passive stretching protocol. This was accomplished by sequentially increasing the amount of passive torque applied by the dynamometer until each subject acknowledged discomfort, but not pain elicited by the stretching protocol. This passive torque setting was then used during the experimental trial to administer the stretching protocol. Stretch tolerance, however, was maximum amount of passive torque applied to the dynamometer that could be momentarily tolerated by the subject. To determine stretch tolerance, the passive torque setting was increased to a supra-maximal level, and the dynamometer was manually stopped by the investigator when the subject acknowledged the momentary onset of pain during the ROM. The stretch tolerance test was used to determine each subject's maximum ROM and MTS. The second visit was the experimental trial during which all testing and stretching took place. Subjects visited the laboratory during normal hours, 8 a.m. through 8 p.m. To avoid differences within the menstrual cycle of men or women, were all tested during menses, which was self-reported to the investigators. All subjects were also asked to refrain from exercise 24 hours before the experimental trial. Hydration status was not monitored before testing, which should be noted as a limitation of the study. Figure 1 shows the schedule of assessments for this research design. Subjects: 13 men, age 20.8 plus or minus 1.8 years, body mass 79.0 plus or minus 15 kilograms, height 176.9 plus or minus 7.2 centimeters, and 19 women, age 20.7 plus or minus 2.5 years, body mass 60.9 plus or minus 8.9, height 165.1 plus or minus 67.6 centimeters, volunteered for this study. None of the subjects reported any current or ongoing neuromuscular disease or musculoskeletal injuries to the foot, knee, or hip. The women were also required to meet the following criteria: have constant normal menstrual cycles for the past 3 months, report no use of any hormonal contraceptives for the last 3 months, and have been menstruating for at least 1 year before the study. None of the subjects were competitive athletes. However, because of their reported levels of aerobic exercise, men 3.6 plus or minus 3.9 hours per week, women 3.9 plus or minus 2.6 hours per week, and resistance training 2.6 plus or minus 2.1 hours per week, women 1.1 plus or minus 1.5, these individuals might be best classified as normal recreationally active participants. This study was approved by the Institutional Review Board for human subjects, and all participants completed a written informed consent form and pre-exercise testing and health status questionnaire before testing. Procedures. Instrumentation: all participants were seated with restraining straps over the thigh and tibia just distal of the knee joint. Each subject's foot was stabilized in a custom-built apparatus described and used in previous studies to measure plantar flexor force, equipped with a sensitive load cell. Omega Engineering Incorporated, Stamford, Connecticut, USA. Figure 2 shows a picture of the subjects situated in the custom apparatus. The leg flexing angle was kept at 0 degrees below the horizontal plane. Full extension and a neutral joint angle joint was considered. 0 degrees, 90 between the foot and the leg. The lateral malleolus of the fibula was aligned with the joint axis of the custom-built apparatus. The subject's foot and heel were stabilized into a thick rubber heel cup and held against the foot plate with straps over the toes and metatarsal so that the straps would not impede any passive foot movement of the ankle joint. The apparatus was also attached to the calibrated Biodex System 3 isokinetic dynamometer, Biodex Medical Systems Incorporated, Shirley, New York, USA, that was programmed in passive mode to stretch the plantar flexor muscles by passively dorsiflexing the foot at 5 degrees a second until the maximum tolerable torque threshold was met. Flexibility assessments and stretching before and after the passive stretch protocol. 2 stretch tolerance assessments were performed during each subject, during which subjects were asked to relax while their foot was passively and maximally dorsiflexed at 5 degrees a second. When the subjects acknowledged their maximum ROM has been reached, the dynamometer was stopped. After the pre-stretching flexibility assessments, a 5-minute rest period was allowed. The stretching protocol was performed in the same position and in the same fashion as the stretch tolerance assessment. 9 repetitions of the constant torque stretch were performed at the predetermined torque threshold determined during the familiarization trial. Each stretch was held for 135 seconds with 10 seconds of rest between repetitions. Immediately after the stretching protocol, 2 post-stretching tolerance assessments were performed in the same manner as described previously. The average ROM achieved during the 2 assessments was used for all subsequent analysis. Electromyography, surface electromyographic EMG signals were recorded from the bipolar preamplified electrodes, Biopic System, Santa Barbara, California, USA, placed over the soleus and medial gastrocnemius muscles. The electrodes had a fixed center-to-center intra-electrode distance of 20 millimeters. And a gain of 350. To reduce intra-electrode impedance, the skin was shaved and lightly abraded, then cleaned with an isopropyl alcohol before electrode placement. Electrodes were placed in accordance with the recommendations of Hermans et al. The soleus electrode was taped along the longitudinal axis of the tibia at 66% of the distance between the medial condyle of the femur and the medial malleolus. Between the base of the medial gastrocnemius and the electrode of the medial gastrocnemius was taped to the most prominent bulge of the muscle. A single disposable pre-gelled reference electrode, AGACO, Quinton Quick Prep, Quinton Instruments Co., Bothell, Washington, USA, was placed on the spinous process of the 7th cervicular vertebrae. All EMG signals were filtered with a passband of 10 through 500 Hz using a zero-phase shift fourth order Butterworth filter. The EMG amplitude values were calculated using a root mean squared RMS function and were quantified with a 200 millisecond epochs corresponding to the same joint angles used to quantify MTS, neutral, 0 degrees, of dorsiflexion. The RMS values were then normalized to each respective EMG RMS amplitude value recorded during the maximal voluntary contraction, MVC, based on the procedures of the Gajadosk et al. For normalization of the baseline EMG RMS was subtracted from the RMS values calculated at each joint angle and during the MVC. And then the baseline corrected RMS values during the passive stretch were expressed as a percentage of the baseline corrected MVC values for each subject. Signal processing. The force, kilograms, position, degrees, and EMG signals were sampled simultaneously at 1 kHz with a biopapic data acquisition system, MP150 WSW biopic systems. During each passive stretch tolerance test, all signals were recorded and stored on a personal computer, Dell Inspire 8200, Dell Incorporated, Round Rock, Texas, USA, to be processed offline using certain written software. LabVIEW V8.5, National Instruments, Austin, Texas, USA. To calculate MTS, the ankle joint angle, degrees, and force, kilograms, signals were plotted as angle force curves, stress strain curves, and fit with a second order polynomial regression model. Musculotendinous stiffness was calculated at the 3 final joint angles, each separated by 2 degrees. What were common to both the pre and post stretching ranges of motion based on the equation reported by Nordes et al. The force values were gravity corrected using a Cousin function that subtracted the weight of the foot platform measured at the neutral joint angle. Statistical analysis. A two-way mixed factorial analysis of variance ANOVA, time pre versus post times gender, male versus female, was used to analyze ROM data. A three-way mixed factorial ANOVA, time pre versus post times gender, male versus female, times angle, 1v2, v3, was used to analyze the MTS data, and a separate four-way mixed factorial ANOVA, time pre versus post stretch times gender, male versus female, times angle, 1v versus 2 versus 3, times muscle, soleus versus mediogastrocnemius, was used to analyze the EMG amplitude data. When appropriate, follow-up analyses were performed using lower order ANOVAs and independent and dependent samples, t-tests with Bonferroni corrections. The assumption of sphericity was not met, so a greenhouse Gesser adjustment was used to correct for this violation. Previous retest reliability data for this flexibility assessment in our laboratory indicated that for 15 young men, 24 plus or minus 3 years, measured on separate days, the interclass correlation coefficient was 0.94 with a standard error of measurement of 2.01%. The SEM for ROM in the present study was 4.6%, ES equals 0.42, and statistical power equals 0.99. An alpha level of P is less than or equal to 0.05 was considered statistically significant for all comparisons. Statistical analysis were performed using SPSS version 16.0 SPSS Incorporated, Chicago, Illinois. Results: range of motion. There was a significant time times gender interclass for the ROM. P is equal to 0.020. Range of motion increased from pre to post stretching for the women. P is less than 0.001, but not for the men. P is equal to 0.066, figure 3. Musculotendinous stiffness. There was no three-way interaction, time times angle times gender. P is equal to 0.258. No two-way interclass for time times angle. P is equal to 0.796, or times gender. P is equal to 0.144. But there was a two-way interaction for angle times gender. P is equal to 0.019, and no main effect for time. The marginal means for MTS collapsed across time, increased such that joint angle 1 is less than joint angle 2, less than joint angle 3 for both the men and the women. And MTS was greater for the men than the women at all joint angles. Figure 4. Electromyographic amplitude. There was no four-way interaction, time times angle times gender times muscle. P is equal to 0.262, and no three-way interaction for time times angle times gender. Angle times muscle times gender, time times angle times muscle, or time times muscle times gender. No two-way interactions for time times gender, angle times gender, muscle times gender, or time times gender. But there were significant two-way interactions for time times muscle and angle times muscle. The marginal means for soleus EMG collapsed across time, increased such that joint angle is less than one joint angle 3, and joint angle 2 is less than joint angle 3. However, the soleus EMG amplitude did not increase from joint angles 1 to 2. The marginal means for medial gastrocnemius EMG collapsed across time, increased such that joint angle 1 less than joint angle 2, and joint angle 1 less than joint angle 3. However, the soleus EMG amplitude did not increase from joint angle 1 to 2. The marginal means for medial gastrocnemius EMG collapsed across time, increased such that joint angle 1 less than joint angle 2, and joint angle 1 less than joint angle 3. However, the medial gastrocnemius EMG amplitude did not increase from joint angle 2 to 3, and the EMG amplitude for soleus and medial gastrocnemius was unchanged from pre to post stretch. Discussion. The main findings of the present study were that ROM increased after 20 minutes of passive stretch for the women, but not for the men. Furthermore, there was no stretching-induced changes in MTS, but MTS was higher for the men than for the women throughout the study. The findings were generally consistent with that of Magnuson et al., and that MTS at fixed joint angles was unchanged after an acute bout of stretching. Magnuson et al. Examined the effects of static and cyclic stretching of the hamstrings on repeated increases in ROM after both stretching protocols, but no changes in MTS. The authors attributed these findings to an increase in stretch tolerance rather than to a change in viscoelastic properties of the MTU. The difference between these studies and the Magnuson et al. Used one 90-second stretch for the left and the right hamstrings, whereas the present study used a constant torque stretching protocol consisting of 9 135-second stretches of the right triceps surae. Therefore, based on the hypothesis of Magnuson et al., the longer stretching duration may elicit viscoelastic changes in the MTU, decreases in the MTS, rather than the simple increases in stretch tolerance. It is unclear why the longer duration of stretching in the present study did not elicit changes in the MTS. We propose 4 potential explanations to why the longer stretching duration of the present study did not decrease MTS but improved ROM in the women compared to their previous studies. Differences between the muscles examined, differences stretching intensities, difference stretching treatments, and gender differences. For example, it is possible that the muscle-specific responses to stretching may exist when comparing the hamstrings and the triceps surae. Ryan et al. Suggested that the smaller distal muscle groups, such as the triceps surae, may require longer durations of stretching to elicit stretching-induced decreases in muscle activation. It is possible that a similar principle could be applied to the changes in MTS. To illustrate, in another study, Ryan et al. Showed that a minimum stretching duration of 2 minutes was required to elicit decreases in MTS because of the duration of stretching in the present study was longer than the minimum duration recommended by Ryan et al. Our findings may also have influenced by this stretching intensity. The subject's main tolerance was also have been affected. The ROM and the MTS results in the present study if they could not tolerate higher stretching intensities. In theory, if the stretching intensity of the present study was less than that of the previous studies that have demonstrated decreases in MTS, then this study may have contributed to the lack of decrease in MTS in the present study. However, Bem et al. Reported no changes in ROM after 3 separate stretching protocols of varying intensities. The authors suggested that this may be attributed to either an increase in passive tension because of delayed onset muscle soreness from the stretching of a greater myotic stretching reflex at higher stretching intensities than increased the acute stiffness of the muscle. Because EMG amplitude increased with joint angle in the present study, figures 5 and 6, our findings supported the hypothesis of Bem et al. That the myotic reflex activation may have limited our ability to measure the decreases in MTS if indeed they did exist. Thus, our findings should be used as cautionary notes for further studies to ensure that the myotic reflex is quiescent while assessing MTS. It is also possible that the difference in stretching protocol could affect changes in MTS and ROM. Ryan et al. Suggested that the constant torque stretching protocol will increase the work performed on the MTU as compared to the traditional static stretching protocol or constant angle stretch, which may or may not be as demanding. Ye et al. Found that a constant torque stretching protocol resulted in greater decreases in MTS than a constant angle stretching protocol of the calf in hypertonic patients, which may have been because of increased strain relaxation or muscle creep during the constant torque stretching. However, Magnuson et al. Reported increases in ROM, but no changes in MTS after cyclic and static stretching of the hamstrings. Therefore, the increases in ROM reported by Magnuson et al. And those reported by the present study may be because of increases in stretch tolerance, rather than changes in the viscoelastic properties of the muscle. Gender differences in the extensibility of the plantar flexor muscle have been reported by Dosick et al. And Riemann et al. These studies show that the MTS was greater throughout the entire ROM and at 10 degrees dorsiflexion for the men than for the women, respectively. The present findings are unique, however, in that only one previous study has examined the passive musculotendinous properties and responses to an acute bout of stretching in men and women. Our study further delineated the gender differences by controlling for both birth control and menses of women. Therefore, our results extended the findings of Dosick et al. And Rindman et al., and suggested that gender differences can be observed in ROM measurements after a bout of stretching, which may be related to fundamental hormonal differences. A few hypotheses have been proposed to explain the gender differences in neuromuscular properties and viscoelastic changes. These include fluctuations in hormonal levels, discrepancies in muscle cross-sectional area, CSA, and anthropometric and differences in passive properties such as viscoelastic stress relaxation and viscoelastic creep. Many studies have examined the effect of estradiol and progesterone on active MTS and anterior cruciate ligament ACL laxity throughout the menstrual cycle with equivocal findings. When a change in MTS or ACL laxity was observed across the menstrual cycle, it was generally at or near ovulation when the estradiol levels peaked. Therefore, because we tested during menses when estradiol levels were lowest, the observed gender differences may have been even greater if we have tested at or near ovulation. Several studies have also reported that strong positive correlation between muscle CSA and MTS. Men generally have a greater muscle mass than do women, which is believed to result in higher MTS values. In agreement with our findings, many authors have been shown that before or without stretching interactions or interventions, men have higher passive and active MTS values than do women. However, after accounting for body weight, body mass, or limb size, no differences were observed in MTS between genders. In addition, it has been suggested that viscoelastic creep responses differ between genders, which is a tissue response that occurs during constant torque stretching. Similarly, Dosick et al. Reported gender differences in viscoelastic stress relaxation during a 60-second static stretch, which suggested that men and women may respond differently to stretching. Overall, the results of the present study indicated that an acute bout of passive stretching increases ROM for the women, but not for the men. In addition, there were no changes in MTS, which is commonly used to assess viscoelastic properties of the muscle. It has been suggested that the decrease in MTS reduces the total amount of strain through a given ROM, which may reduce the risk of strain injuries. If the goal of stretching interventions is to increase ROM and decrease MTS, the findings of this study indicated that men may have to stretch at a higher intensity or longer duration to achieve the same increases in ROM as women. In contrast, a stiffer MTU is thought to be advantageous because it can better withstand rapid and large forces compared to a compliant system, thus reducing the likelihood of ligamentous injury for women who are at a 2 to 8 times greater increase in sustaining an ACL injury than men. Maintaining MTS may be an important factor in reducing this risk because MTS was not decreased after stretching. These findings indicate that although it is unknown if stretching affects the risk of injury, it may be a safe treatment before competition. However, future research is necessary to determine when the stretching is applied before performance and how long the changes in ROM may exist or last. Practical applications. The findings of this study suggest that passive stretching increases ROM for the women, but not for the men. But there were no changes in MTS. Thus, the women experience increases in stretch tolerance, but not changes in muscle stiffness. Practitioners who use stretching may want to consider the possible gender differences in passive stretching responses, and that increases in ROM may not always reflect decreases in MTS. Therefore, men may have to stretch for a longer duration or at a greater intensity to achieve similar increases in ROM as women. It is important for coaches and athletes to know that this type of stretching may not always result in the desired effects, increases in ROM or decreases in MTS.